Hello and welcome to Chapter 2. Today we'll be talking about fluid electrolyte imbalances and acid-base imbalances. So in order to start talking about fluid and electrolyte balance or imbalances, it's important to understand the concept of water. And water is made up of about 60 to 70% of our bodies, and it has a very large composition. That means that water serves a very important role in our bodies. It's very essential to maintain homeostasis. It's important for metabolic actions and reactions to occur. It's important for the transportation of different proteins, molecules, cells throughout the body, and it also helps the facilitation of movement with our body parts. So, water holds a very important role in our body, and it's important to understand that when our water balance is knocked off, then we see alterations as a result. So here, I really like this chart from your book because it sort of explains the different compartments within the body. You have the intracellular compartment, which is the fluid that resides inside of a cell, and then you have the extracellular compartment, which is all the other fluids on the outside of the cells, and this consists of different types of fluids. You have intravascular fluids, you have interstitial fluids, you have cerebrospinal fluids, transcellular fluids, and even other various secretions that make up fluid that are on the outside of the cell. Again, intracellular compartment is the ICF, and we consider this fluid that is located on the inside of the cell. And then you have extracellular compartment, which is the fluid that resides on the outside of cells. It's important to note the movement of water. So, when we talk about the movement of water, this is talking about how much water or fluids that we're intaking and how much fluids that are exiting or leaving the body. We classify this as fluid intake and fluid loss. Ideally, fluid intake should equal the amount of fluid loss in order to remain homeostatic, but as we all know, sometimes this can be thrown off. When we talk about fluid intake, this is considered the things that we ingest, regular fluids, any type of fluids, and even foods that have fluids associated with them. When we talk about fluid loss, it's considered fluid loss through urine, feces, perspiration or sweating, exhaled hair, and even if we vomit or have emesis, that's also a form of fluid loss. It's also important to note that when we have equal and intake versus equal loss, that our bodies remain homeostatic and our bodies don't feel these fluid shifts. Now, when we have fluid that circulates throughout the body, it's important to note that this process is completed by filtration and osmosis, and those terms we'll talk a little bit about later. But just know that this is heavily directed on membrane permeability, or when we talk about cells, when fluids come through the cells, the membrane of that cell is highly dependent on how much water can go through and how much water can exit. Also, if we're talking about moving between different compartments, it's also important to note hydrostatic pressures versus osmotic pressures. When we talk about hydrostatic pressure, this is kind of like the push or the force that pushes water inside of a compartment versus osmotic pressure, which helps to pull fluid out of that compartment. So, water is just like what it says, it's very fluid and it does take these pressures and forces, filtration, and osmosis in order to allow fluids to shift throughout the body. So this slide is focusing on the movement of water in association with particles, or other words, solutes. So water does help with the concentration of solutes, in that if there are areas that are higher concentration or lower concentration, water does flow between those areas to help maintain balance of fluid and particles and electrolyte balances. So let's talk about the first one. We have filtration, and this is basically the movement of water and solute. So they're moving together from blood in high pressure area to an area that has low pressure. So both water and solutes are moving in the same direction. In diffusion, we have the movement of solutes. So again, this is the particles like sodium, potassium, glucose. the particles or solutes are moving from an area of high concentration to low concentration. And again, this is just the particles moving, not water. And again, a lot of times this will happen when there's higher concentrations and they want to pretty much exist in an area that does not have as many of the same particles. So you'll see the act of diffusion where you see these particles just moving from one area to the next where there's not a high concentration. So again, filtration is the movement of solutes and water, whereas diffusion is just the movement of solutes only. Next, we have osmosis, and this is just the movement of water from an area of low solute concentration to high concentration of solutes. So, what that means is that water is shifting from an area where you don't have as many solutes to an area where you do have a lot of solutes, and the water is acting to hopefully help not have as much particle concentration. So, this is heavily focused on the movement of water. This is different from diffusion. Again, diffusion is just the movement of particles, whereas osmosis is just the movement of water. Next, we have active transport. And this is where we have solutes that move from different areas, but it has to pretty much be forced inside of a different compartment. So you do see the movement of the solutes using a carrier. Normally, these carriers are proteins that have to be activated. A good example of that is the sodium potassium pump. And what that does is that you have to activate it with ATP. ATP touches the protein changes shape, and it engulfs whatever particles inside in order to help transport them to the other side, whether it's intracellular or extracellular. So the active transport means that you have to have something to help force the solutes into different areas. So these are different ways that water and particles can move. This is basic A and P, and it's really good background information to know. Now we will talk about the regulation of water and electrolytes. The first thing we'll talk about is thirst, and this is the most potent regulator of water balance in the body. And what I mean by that is that our bodies know when we need water. So thirst is kind of the first indicator that, hey, the body needs more intake. And it helps regulate water balance when we respond to our thirst mechanism. It is stimulated by osmoreceptors in the hypothalamus, which is located in the brain. So when we start getting thirsty, these osmoreceptors are activated, and it tells us that, hey, we need to intake more water. If not, then you do see issues ensue from dehydration because we are so thirsty. So, thirst is the number one regulator and notification system of the body to know that, hey, we need more water to maintain water balance. The next thing we'll talk about is antidiuretic hormone. And this hormone is really great because it helps assist with the reabsorption of water from the kidney tubules. What that means is that when our kidneys are activated and there is no antidiuretic hormone circulating, the body is going to excrete fluids. The kidneys help with water excretion or fluid excretion. So when we have antidiuretic hormone, look at what the word says, antidiuretic. It's preventing diuresis from the kidneys. So therefore, if antidiuretic hormone is circulating, that means our body is going to hold on to the water that it already has. Aldosterone is another hormone, and it also helps with the reabsorption of not only just water but also sodium. And it's important to note that sodium generally follows water. So when sodium is reabsorbed, water is reabsorbed, and this helps our bodies hold on to the water that we have. We have atrial natriuretic peptide and T type natriuretic peptide. These are um, molecules that, or peptide molecules, proteins that are synthesized by myocardial cells, and it also helps with the regulation of sodium levels, potassium levels, and it also helps regulate fluid. We won't necessarily focus too much on AMP or TMP, but it's just good to know that these mechanisms help with the regulation of water and electrolytes. So, what I want you to focus on is thirst, antidiuretic hormone, and also aldosterone. But again, it is good to know that AMP and TMP help also with the regulation of cells. Okay, let's talk about what happens when our bodies don't do regulation well. So, this occurs when we have fluid excess. So, this means that we have too much water on the body and we're not getting rid of it in a efficient rate. So, we tend to hold on to the fluid. When we're holding on to fluid or have fluid excess, this means that we have an excessive amount of fluid in the interstitial compartment. This causes enlargement of our tissues, and ultimately edema is swelling. So swelling occurs within the body when we have too much water. You can have localized swelling, which means that it's only in one or a few places in the body, or you can have swelling that is fully dispersed throughout the whole body. Regardless, it's not a good thing because it tells us that our body is in fluid overload or in fluid excess. When we have this swelling going on, it does impair tissue function and ultimately it can impair organ function. And it can trap drugs inside of the interstitial fluid, which means that drugs are not getting to the places that it needs to go, or it could completely wash them out and not have as much of an effect on the body. Here are the different causes of edema. And again, edema is swelling. So you can have increased capillary hydrostatic pressures, which is caused by high blood pressure or increased blood volume. You can have the loss of plasma proteins, such as albumin, or you can have decreases in plasma osmotic pressures. You can have the obstruction of lymphatic circulation, where this causes localized edema. You do see this with individuals that have lymphedema. If you've seen very swollen legs, or sometimes you can have lymphedema in the arms, and it's just localized to that one area. Normally, that's an issue with obstruction of your lymphatic system. So, excessive fluids and protein are not in your general circulation and they're still in the lymphatic system and they're not able to get out. So you do see swelling when it comes to that. You can have increased capillary permeability, and that also causes localized edema. Sometimes, when you have increased capillary permeability, that's a direct result of having an injury or an inflammatory response or even infection. So, when our capillaries are permeable, that means they open up and they allow more fluid to come into those areas, especially if it's damage due to injury or an inflammatory response. So, increased capillary permeability can cause edema as well. And of course, burns and wounds or even bacterial toxins can result in widespread edema. And with the burns and wounds, that's a localized injury. And again, it kind of leads back to our previous point with increased capillary permeability. You do have swelling that can ensue due to wounds and burns. And even if there's bacterial toxins, that leads to the infection part where the body is trying to fight off these infections or the organisms that are not supposed to be there. So you do see swelling as a result of that. We have different effects when it comes to fluid overload and edema. So the first thing is that you can have, of course, swelling, and sometimes the area that is swelling, you do become pale or red in color. You do see pitting edema, and this is due to excess interstitial fluid. And most times when we have pitting edema, if you were to do a physical assessment on the patient, you would press your fingers on the area that is swollen and you would look to see if there is an indentation. Most times, if a pit or the depression remains, that means that the edema is pitting. And what that means is that this excess interstitial fluid is moved aside when we press on that area of the patient. We do normally grade pitting edema from 1 plus to 4 plus, depending on how long the depression remains. 1 plus is that it goes away fairly quickly, whereas 4 plus means that that depression or that pit stays on the skin for a while. And when we have edema, of course, this is a issue of fluid backup. So we do see increases in body weight as a result because the body is not able to get rid of the extra fluid. You do see some functional impairment. Sometimes it goes to the joints, and that particular joint that's affected can't move as well. You do also see impaired diastole, or the lower number of your blood pressure is affected. It's not as efficient. And you also have a reduction in vital capacity. So functionally, if you have edema, it's not you're not able to move as efficiently, and you do start seeing vital sign changes as a result. Of course, it can be painful to have edema. It can put pressure on nerves, and you can see some neuropathy from that. And again, this is a local pain. You can also have swelling in the brain, which is called cerebral edema. Normally, that's associated with some sort of headache that is very hard to get rid of, and you can't make it go away. You can also have the kidneys and liver and other organs, for that matter, they can stretch as a result of the edema, so that causes a chronic pain. So, edema is, if left untreated, can cause all of these issues. We can go into impaired arterial circulation. Um, when you have edema and your blood is not going to the areas as efficiently as it could. When we talk about arterial, we're talking about blood going to different organs and perfusion. You can get ischemia or oxygen deprivation, which can ultimately cause tissue breakdown in those areas. So, if again edema is left untreated, and depending on where it is and how bad it is, you can get ischemia and oxygen deprivation to that area of tissue, and you can see where that tissue may start dying off due to the edema. Of course, it can cause dental complications as well as skin breakdown. Again, if left untreated, especially when it comes to skin breakdown, you start seeing weeping or fluids coming like out of the wounds themselves. You do have a higher risk of getting pressure ulcers when you have edema. It's very important when we look at this in the clinical perspective, because edema, again, left untreated, can cause a wide array of other issues. Let's talk about what happens when we have a fluid deficit. So, this is also known as dehydration, and this is known as insufficient body fluid in the body. And it can be caused by just not taking in enough fluids or inadequate intake. It could be caused by excessive loss. And when we talk about loss, that's included vomiting, defecation, urination. Excessive loss in these areas can cause dehydration. Even perspiring, if you sweat profusely or have diaphoresis, you're also losing water. It can cause dehydration. Or it could be caused by a combination of both of these areas. If you're nauseated and vomiting, you may not be as willing to take in fluids because you're dry heaving and throwing up everything that you have. So, dehydration can be caused by either one or the other, or both, depending on the situation and cause. When we talk about dehydration, as we did with edema, we looked at body weight. So, the change in body weight for dehydration would also be the same, with the exception that you would lose weight because you don't have volume composition. So, this is different from fluid excess. When you have fluid excess, you gain weight. When you have fluid deficit or dehydration, you lose body weight. And it's also important to note that because of these changes, it's more serious. Dehydration is more serious in those that are younger or infants and those that are older, because they are most affected. For infants, a lot of their body water composition is greater, and it's really hard to replace fluid in an infant. So if they lose, it's a very serious matter, because they respond to their fluid deficit very severely. And just like older adults, it's kind of the same thing. You have immunocompromise, you have degenerative changes that will cause an older adult not to be able to take in fluids, and you run the risk of them becoming dehydrated as well. Water loss may also be accompanied by loss of electrolytes and proteins. And again, I highlighted this kind of in the first part of this slide, where you can lose water from emesis or vomiting, from diarrhea. A lot of times it's an excessive loss because it's very violent when those issues occur. So you do start seeing electrolytes going as well as proteins. Now, when we look at dehydration, a lot of the times we're looking at skin turgor, and this is a part of our physical assessment. We're looking at if the skin tints or if it's non-tinting. So when we look at skin turgor, it helps us review if there is hydration or not. And a normal response should be non-tinting. With the causes of dehydration, it's important to know all of these areas. So, first, we highlighted on the last slide where you have vomiting and diarrhea, and it does result in numerous electrolyte and nutrients loss, as well as sugar. We have drainage or suction of any portion of the digestive system, and you can see this when it comes to an NG tube. If we're suctioning out fluids from the abdomen, or if we're suctioning out anything from the abdomen, it's important to know how much water is lost because we can send the individual into dehydration or even a fluid electrolyte imbalance from taking that excess fluid out of their bodies. You do have excessive sweating where you see a major loss of sodium and water. Again, sodium tends to follow water. When you perspire, that's water or fluids going out as well as the salt. That's why when you sweat, it does have a salty tinge or taste to it because that's sodium leaving with the water. When it comes to ketoacidosis, you have this is a blood sugar disease where you have very, very high blood sugars. And with the loss of fluids and electrolytes, not only are you losing these within the urine, because one of the signs and symptoms of diabetic ketoacidosis is polyuria. Polyuria means that you have excessive urination. With this fluid loss and urination, you do see a glucose in the urine, you do see electrolytes coming out, and you do see fluid. So again, this can cause an area of dehydration for individuals suffering with DKA or diabetic ketoacidosis. You also have insufficient water intake, of course, if they're elderly or an infant, even an unconscious person. You can have dehydration there, especially with the elderly, those that suffer with dementia. They don't sometimes remember to drink fluids or to help rehydrate their body. So you do see this population of individuals suffer with dehydration simply because of the cognitive changes that they're experiencing. And if you're using formula for an infant, if it's more concentrated, then you run the risk of causing dehydration because the particles compared to the amount of fluid in that formula is greater. So they're getting fluids, but it's not just fluids, it's more concentrated with formula. So that doesn't help an infant. So these can all cause or issues that can cause dehydration, and it's important to know that in your practice. Now, here are the effects of dehydration. Of course, you'll start in your physical assessment. You're doing head to toe. You'll start seeing dry mucous membranes in the mouth or the oral mucosa. You'll see decreased skin turgor or elasticity. This is where we'll start seeing tinting of the skin. You'll also see lower blood pressure. It's because you don't have as much volume in the body. When you have decreased volume, generally your blood pressure decreases. We assess this by feeling pulses, and we'll see that the pulse is weak or thready. Normally, when we're grading a pulse, it can be from 1 plus all the way up to 3 plus or 4 plus, depending on what literature you're looking at. But normally, a weak and thready pulse is graded as a 1 plus. It's still there, but it's not as bounding or it's not as present as it should be. We can also see that this individual will be incredibly fatigued. We'll also see increases in our hematocrit values, and what a hematocrit value looks at is found on our complete blood count, just like where hemoglobin is found. The hematocrit indicates that there's a higher proportion of red blood cells compared to the fluid in the blood or the water in the blood. So if hematocrit increases, that tells me that the fluid concentration in our body is decreased. And you'll also see decreased mental function. This can show up as confusion or loss of consciousness because our brain has cells and the cells need water as well. So if they don't have as much water circulating, you don't have functioning brain cells, which would present as our neuroassessment occurs as loss of consciousness or confusion. So what our body likes to do is try to compensate due to these issues with dehydration. So, if you're dehydrated, the body is going to try and save itself or save the volume that it can to help the body continue to thrive. So, this is called compensation, but if your body is in a compensatory state, it's important to know that this is not good and eventually these mechanisms can fail. So, there are several ways that the body compensates with hydration. The first is thirst. So, we talked about how thirst is a regulator. The body is going to tell you, hey, I'm thirsty, I need water. You're going to feel increases of that. And then you'll start seeing increasing heart rate. And this is due to the less volume composition that's located in the body. So it has less to work with and it's still trying to circulate it to the body to help perfuse. So you'll start seeing the heart rate increase to help compensate for that. You'll start seeing the constricting of blood vessels, which can lead to cool skin or pale skin. And you'll also see that the body is producing less urine. This is a response of the kidneys. A lot of times when we're dehydrated, you'll see an increase in the urine specific gravity, um, because our kidneys are trying to compensate for the lack of volume that we have. So the kidneys are trying to hold on to what it has, and it will concentrate the urine. So it'll hold on to the fluid, and the particles it'll just excrete those. So that's why you see increased specific gravity. Um, and you'll also see an increase of aldosterone and antidiuretic hormone as a result of this as well. So this chart is a really nice overview of the effects and physical assessment of your client, and it's important to know the differences. So again, when we talk about edema, this is fluid excess. We have too much fluid on our bodies, so you do see weight gain. You can get pale, red skin color, localized swelling. This can be in the eyes. This is where the periorbital area is. You can have localized swelling in the abdomen, especially we call this ascites. You can see it in the feet and the hands. You can see an individual get seizures from being too overloaded. You'll see some pulmonary congestion. Not only will you hear coughing, but you'll hear crackles and rails. And as far as the laboratory values you should be familiar with, it should be hematocrit values are decreased. You see decreased sodium levels because there's more volume of water compared to the particles of sodium. And then as far as our urine, you'll see low specific gravity and high volumes of fluid. When we talk about fluid deficit, you see sunken eyes, you'll see decreased skin turgor, dry mucous membranes, you'll get more thirsty, you'll see weight lost, you'll have a weak and thready pulse, low blood pressure. You'll also see these individuals get orthostatic hypotension very quickly because they already have a low blood pressure. So when they change positions, that low blood pressure just gets lower. So you'll see orthostatic hypotension. They'll be fatigued as well. You may see dizziness, stupor. You'll have an increase in body temperature. This is very characteristic of dehydration, that increase in body temperature, because there's not water in the body to help buffer that temperature change. You'll also see increased hematocrit values, and we discussed that on the last slide, how that comparison of red blood cells compared to the amount of fluid that's in the body. You'll see increased or higher values of electrolyte in the body when you have a fluid deficit. So that's where you start seeing hypernatremia, hyperkalemia, all the hyper with the electrolytes. And then, of course, with the urine, you have higher specific gravity because the kidneys are trying to hold on to the urine that it has, so it'll concentrate the urine, which makes you just pretty much pee out the particles and keep the fluid inside of the body. And of course, you have low volume as a result of that. So, third spacing is an important concept that we talk about, and this is basically where we have a fluid shift out of circulation of the blood or volume of our blood, and it goes into body cavities where it cannot be accessed by the blood anymore. So, it just sits there. Um, Normally, the fluid will remain in the third space until we intervene or do something about it. So again, it's still inside of the body, but it's in a compartment or a space where it's not being utilized by circulation anymore. So when we try to identify third spacing, we normally use hematocrit values and electrolyte concentrations to identify if there's third spacing. Um, if it's a burn, normally third spacing is kind of associated with that, especially with the more severe burns, your third degree burns. Um, Full thickness burns, you'll see third spacing as evidenced by edema in your wounds. Next, we'll talk about electrolytes. We've just talked a lot about fluids, so let's get into what electrolytes look like in the body. So, these are the several electrolytes that I would want you to know for this class and moving forward. You have sodium, you have potassium, calcium, magnesium, chloride, and phosphorus. The first one we'll talk about is sodium. And our normal sodium values range between 135 to 145 millicues per liter. It's important to note that this is what our textbook has defined our values as, and this is what we'll use for testing purposes. However, these values can change based on the facility that you go to. So just make sure you check the parameters before you consider interventions for hypernatremia, hyponatremia, so on and so forth. So, the first one is sodium imbalance. So, we have hyponatremia, which means that there is a decrease in sodium levels. So, normally this is defined as less than 135 millicues per liter. And when we're in hyponatremia, we have different signs and symptoms that occur. So, this can be anorexia, nausea, cramps. You have lethargy, muscle weakness, fatigue, headaches, confusion, seizures, and of course, decreased blood pressures. So, when we have hyponatremia, generally the cause is fluid excess. And what that means is that we have too much fluid in the body compared to the amount of sodium in the body. It can also be a result of just direct loss of sodium, or it can be considered with the dilution of sodium. So, all of these things can cause hyponatremia. Um, Sweating can cause hyponatremia. You can have vomiting and diarrhea. Sometimes you can have the use of diuretic drugs. Even low salt diets can cause hyponatremia. And we also have hormonal imbalances that can cause hyponatremia, such as uh, adrenal insufficiency, excess antidiuretic secretion. We call this syndrome SIADH, but we'll get into that with the hormone section. You can also have insufficient aldosterone levels. Sometimes we see hyponatremia with chronic renal failure and again with excessive water intake. So, all of these areas can cause us to have low sodium levels compared to the amount of fluid that we have in the body. The next one we'll talk about is what the effects are of hyponatremia. So you can have nerve conduction that is impaired. Sometimes the manifestations include muscle cramps, fatigue, abdominal discomfort, and of course, you have cramping that can result from hyponatremia. You can also have hypovolemia or decreased blood pressure, and you can also see brain cell swelling, which can cause confusion, weakness, seizures, headache, all of those things. So, hyponatremia, if left untreated, can get really bad really fast. So, it's important to correct the cause with treating with a hypertonic solution. And we'll talk about what a hypertonic solution is. The next thing is hypernatremia. So, this is when we have an excessive amount of sodium in the body. So, this is characterized by thirst. You do have dry mucous membranes. The oral mucosa is dry and sticky. You do see lethargy and hypernatremia as well. Some agitation. Of course, you'll see edema and even elevated blood pressures. So, hypernatremia is characterized by excessive sodium levels, and generally we'll call this greater than 145 millicues per liter. And some of the causes are too much salt from the diet. So, you can have can have too much salt in your diet. You can have so much salt in the body that you're taking up what water excess you have. So that can be a large amount of sodium. Or it can be caused by the loss of water that is faster than the loss of sodium. So remember earlier in this lecture, um, we were talking about fluid balance, and ideally we want fluid loss to be equal to the amount that we take in. Well, if we have more water loss than the amount that we take in, then you can see hypernatremia because there's not enough fluid to help balance out the amount of sodium that's in the body. So that would be something that can cause hypernatremia. Watery diarrhea, you can have prolonged periods of rapid respirations that cause hypernatremia. Even the loss of the thirst mechanism. Sometimes individuals that have brain damage, that hypothalamus that helps trigger those osmoreceptors, when that's damaged, you can have the loss of your thirst mechanism. So you just are hypernatremic simply because you don't know when to drink. And also, you can have hypernatremia as it's associated with insufficient antidiuretic hormone, which means that you are having dilute urine. Um, and that means that you're keeping in the sodium levels and the urine is leaving. That's called diabetes insipidus, but we'll talk about that in a later lecture. So, the effects of hypernatremia include firm subcutaneous tissues. You have increased thirst. Of course, we talked about the dry mucous membranes. You have decreased urine output. You have weakness and agitation. So, all of these things can be the cause and, well, really the effects of having too much salt in the body. And as far as our signs, again, this chart really highlights what those signs and symptoms are. Again, that's thirst, weakness, lethargy, agitation, edema, and elevated blood pressure. So just make sure you familiarize yourself with the normal values of sodium and what those imbalances look like and what they cause. Next, we'll talk about potassium imbalances. So, our normal ranges for potassium is 3.5 to 5 millicues per liter. When we have hypokalemia, this is characterized as a serum potassium level less than 3.5 millicues per liter. So, the result of this can be from just excessive losses from diarrhea, particularly. It can also be associated with the use of diuretic drugs. And the one that I want to point out specifically is furosemide, or otherwise known as Lasix. Lasix is a loop diuretic, and what it does is that it does a really good job of diuresing the patient or removing fluid from the patient. But with that, you also are removing a lot of potassium with this drug. So we do see hypokalemia in this population sometimes. So if that is the case, we have to be monitoring for hypokalemia. So we'll oftentimes pull um, basic metabolic panels or complete metabolic panels just to monitor the potassium levels in the blood. Oftentimes, these individuals will have to get a potassium supplement or replacement simply because of the function of this diuretic drug. So, again, Lasix is not potassium sparing or reserving. It is something that removes potassium very aggressively. So, you do see hypokalemia in this patient population. Um, sometimes, if you Sometimes, if you have hypokalemia, it can increase heart toxicity, such as digitalis. So, it's important to make sure that you monitor for things like this in this patient population. Another way that we see hypokalemia is in our hormone imbalances. So there's a hormone called aldosterone, and if you have too much aldosterone, or even mineralocorticosteroids or glucocorticosteroids, such as in the issue with Cushing's disease, you have too much. It does promote the retention of sodium, but just like the retention of sodium, we have that sodium potassium pump. As we are retaining sodium, you have more excretion of excretion of potassium in this condition, which can cause the individual to have hypokalemia. Of course, as always, if you don't take in enough potassium, you can have hypokalemia simply because your diet does not allow that. It can also be a result of eating disorders or even starvation. We do see hypokalemia in individuals that suffer with anorexia nervosa, especially. And it can also be due to alcoholism. When we have an individual that has diabetic ketoacidosis, a condition that is the result of high blood sugars, normally in the 500, 600, 700s and up, we do have to treat them with a medication called insulin. Well, sometimes when we give insulin, the way that this medication works, it helps to excrete the potassium out of the body. So, and it does it at a very aggressive rate. So we lose potassium in the treatment of diabetic ketoacidosis, and in this patient population, um, we do see hypokalemia and would have to treat it appropriately. So when we talk about hypokalemia, it's important to note that potassium is heavily associated with the heart. So any imbalance, whether it's hypokalemia versus hyperkalemia, either way, you can result in cardiac arrest. So in this case, you can get cardiac arrhythmias or not normal cardiac rhythms that can result in cardiac arrest. And it's very, very important to know. So when we talk about cardiac arrhythmias. This is changes in our telemetry patterns or our EKG, where we see prolonged repolarization, and sometimes that prolongation can be so long that the heart actually stops, and we do see cardiac arrest. Hypokalemia can also cause issues with muscles. It can cause issues causing pins and needle feelings, such as paresthesias. It can also cause decreased digestive tract motility, which can ultimately result in decreased appetite. So that further doesn't help someone that has anorexia nervosa because they already do not want to eat, and then loss of potassium makes that feeling become more aggressive. And also in nausea, of course, because we are, or even vomiting because we're losing electrolytes as we're having emesis spells. If you do have very severe potassium deficits, you can see shallow respirations. You can also see in people that have renal impairment, such as those with chronic kidney disease or even end stage renal, you can see issues with potassium. More specifically, you have hypokalemia. Again, this is people that have impaired renal function. Those that have increased urine output or polyuria, such as those in diabetic ketoacidosis, they can also lose a lot of potassium through their urine simply because they're urinating more frequently. That is one of the telltale signs of diabetic ketoacidosis. So you do see kind of this overlap of those that have diabetic ketoacidosis and hypokalemia, even with the treatment, down to having to urinate a lot because that's just one of the signs and symptoms. You do see these issues occur. You can have nocturia and postural hypotension as well, fatigue, muscle twitch, leg cramps, weakness, nausea, constipation, postural hypotension, polyuria, and even your serum pH levels, they can be elevated, which is an alkalotic state. So we do see metabolic alkalosis a lot in those that have diabetic ketoacidosis and potassium imbalances. The next one we'll talk about is hyperkalemia, hyperkalemia, guys. And this is when we have potassium levels that are greater than 5 millicues per liter. Some of the causes of hyperkalemia can be a deficit of aldosterone. And remember, that is something that helps with water retention and sodium retention. So if you don't have that hormone there, you don't have as much sodium in the body, and that sodium potassium pump doesn't work as well. So you do see the retention of potassium, which causes the hyperkalemia. Of course, in renal failure, and this is those that have end-stage renal disease, their kidneys aren't functioning as well, so you do see the retention of potassium in these individuals. Even with the use of potassium-sparing diuretic drugs, again, this is different from Lasix or furosemide. Lasix and furosemide is a loop diuretic, whereas potassium-sparing diuretics such as spironolactone can prevent potassium from being excreted, but sometimes if we give them too much of this, you do start seeing hyperkalemia. Anything in excess is not good for the body, so it's good for treatment, but at the point that it becomes excessive, you do see these potassium imbalances, particular hyperkalemia. Um, you can also see hyperkalemia with those that have severe acidosis. So in hypokalemia, you have alkalosis. When you have too much potassium, you have acidosis or decreased pH because of displaced potassium from the cells. So you do see some acidosis as a result from that. You also have leakage of intracellular potassium that can um, go inside of the body. And this is normally characteristic of those that have like trauma injuries, crush injuries, or even burns. So these would be individuals that we look at when it comes to hyperkalemia. Just like with hypokalemia, you have cardiac arrest. With hyperkalemia, because it's potassium that we're dealing with, you can have cardiac arrest with that as well. You'll have arrhythmias as well. You do see some muscle weakness and even paralysis as you have more hyperkalemia or elevated potassium levels. You can also have nausea, fatigue, and also paresthesias is common in this patient population as well. The next one we'll talk about is calcium, and our normal values are 9.0 milligrams per deciliter to 11 milligrams per deciliter. So when we talk about hypocalcemia, this is a serum calcium level that is less than 9 milligrams per deciliter. The causes include hypoparathyroidism, where we have a decreased parathyroid hormone, which ultimately results in decreased calcium absorption. You can have this caused by malabsorption syndromes, where you're not able to ingest the absorption of vitamin D or calcium. You can have deficient serum albumin levels. You can have increased serum pHs, which generally results in alkalosis, and even in renal failure. It results from the retention of phosphate. You'll oftentimes see an inverse relationship between calcium and phosphate levels. As phosphate increases, then calcium decreases. So, if in the body phosphate ions are increased, you do have the loss of calcium, which can result in hypocalcemia. Um, and again, this is really because vitamin D is not activated. So you have hypocalcemia that can result from all of these conditions. Now, when we have hypocalcemia, it can affect the body in several ways. In assessment pieces, you can see Chevosik sign, which is the spasm of the lip or face when it is tapped in front of the ear. So the face will literally move, or really the lips will really move and have like a muscle spasm when it is tapped. That's how you know that you have um, hypocalcemia. You can also see Trousseau's sign, which is where we use a blood pressure cuff that blocks circulation to the hand. And when you see a spasm in that area, it's normally a prolonged contraction or a cramp, and it does indicate low serum calcium levels. When you have laryngeal spasm, this is really where the airway is compromised. And in hypocalcemia, this is actually a priority item because we don't want airway to be blocked. When you have a laryngeal spasm, it has the potential to block the airway, which can cause an issue and respiratory arrest. Paresthesias are common in hypocalcemia. Abdominal cramps are also common. And you can also see that in the heart, particularly, you don't have as aggressive of a heart contraction. Normally, they're weak, and you do see arrhythmias as a result, and you can also see your blood pressure drop as a result. When it comes to hypercalcemia, this is a serum calcium level that's greater than 11 milligrams per deciliter. And excessive calcium levels can be caused by just the uncontrolled release of calcium from the bone. The bone is a very large reservoir, and of course, we have skeletal bones all over the body, but this is a very large reservoir for calcium. Sometimes when you have malignant bone tumors that are breaking down calcium from the bone, you do see this influx of serum calcium levels as a result. You can see this with hyperparathyroidism. Um, Immobility can also cause high calcium levels simply because they're not being utilized, the bones, and they're not being utilized. So you do see a breakdown, or otherwise known as demineralization, with the bones. You can see increased calcium levels due to diet. So you can have excess dietary calcium, or even due to excessive vitamin D, because vitamin D does help bring calcium into the body. So when you see an increase in vitamin D, normally you see it associated with calcium levels. You can also have increased calcium levels with milk alkali syndrome, and this is where you have increased milk and antacid intake. So, literally, just drinking more milk and having antacids can elevate your serum calcium levels. So, what are the effects? You have apathy and lethargy. You can have anorexia, which in this case means you just don't have the desire to eat. It's not anorexia nervosa, it's just described as decreased appetite. We call that anorexia. You can have nausea, constipation, polyuria, thirst, kidney stones, and again, you can have cardiac arrhythmias. You do have strong cardiac contractions, whereas in hypocalcemia, you have weak cardiac contractions. But either way, it does cause an arrhythmia, and you do see increases in blood pressure as a result. Um, if you have too much parathyroid hormone, I should go back and talk about this, but if you have too much parathyroid or hormone, bone density is decreased, which can increase your risk of getting a fracture in bones. We call these pathological fractures, and especially in the hip where it's weight bearing, you can have more pain in the bones. And you can also see more kidney stones develop as a result of high calcium levels simply because there's more circulating calcium and the kidneys are trying to excrete them. You do see renal calculi or kidney stones as a result. So when we talk about magnesium imbalances, our normal ranges for this lecture are 1.8 to 3 milligrams per deciliter. And it's important to know that magnesium imbalances are rare, but when we do see them, we want to recognize the signs and know to treat them. Generally, when we have hypomagnesemia, it's associated with complications due to the use of diuretics, DKA or diabetic ketoacidosis, hyperparathyroidism, or even hyperaldosteronism. When we talk about the effects, we have muscle hyperirritability, or this could be tremors, spasms, repetitive movements. You can see insomnia, personality changes, and you can see increased heart rate with arrhythmias. When we talk about hypermagnesemia, this normally occurs in association with renal failure. The effects are lethargy, decreased reflexes. You can also see cardiac arrhythmias and even decreased neuromuscular function. The main thing is that you just want to correct the overlying cause of either hypomagnesemia or hypermagnesemia. They are rare, but in the case of hypomagnesemia, we like to replace with magnesium. And sometimes we use magnesium in the pregnant population as well as a tocolytic, but that's later for a different discussion. But just know that magnesium replacement is important. We also have hypermagnesemia. If it's with renal failure, normally dialysis is a good way to help correct these values, especially with the electrolyte imbalances. When it comes to our phosphate imbalances, our normal values are 3.0 to 4.5 milligrams per deciliter. When we talk about phosphatemia, it can be caused by, well, particularly hypophosphatemia, it can be caused by malabsorption syndromes, diarrhea, excessive use of antacids, alkalosis, and even hyperparathyroidism. The effects of it is tremors, weak reflexes, paresthesias, confusion and stupor, anorexia, difficulty swallowing or dysphagia. You can also see dysfunctional blood cells. You can see the decrease of oxygen transport. You can see decrease in clotting, and you can even see phagocytosis decrease, or the engulfment of bad cells or antigens. That'll decrease in the presence of hypophosphatemia. As far as the causes of hyperphosphatemia, normally it's a result of renal failure. We normally dialyze patients to help with their phosphate levels, but we can also give them something called a phosphate binder, and that's given absolutely with their meals to help control their serum phosphate levels. We can also see hyperphosphatemia in those that have cancer. When they're in chemotherapy, as you know, we're not only killing off the tumorous cells, but they're also killing off good cells. And so, with the destruction of those cells, you do see the release of phosphate, and sometimes it can be detrimental. So, we do have to watch that as they're getting their chemotherapy treatments. As far as hyperphosphatemia, the manifestations are the exact same as hypocalcemia. Earlier in this lecture, I mentioned that there's an inverse relationship between calcium and phosphate levels. As calcium levels go down, phosphate levels go up, and as phosphate levels go down, calcium levels go up. So they have an inverse relationship. So normally, if we see hypocalcemia, those effects are paired with hyperphosphatemia. So just make sure you note those similarities. Chloride is an anion, and our normal values are 96 millicues per deciliter to 106 millicues per deciliter. When we have low chloride levels, we call this hypochloremia. And it's important to know that chloride normally follows sodium levels. So when we see a decrease in sodium levels, we see a decrease in chloride levels. So they're heavily associated with each other. But one of the things with hypochloremia is that it is heavily associated with alkalosis, especially with vomiting. Again, we are losing sodium, but we're also losing chloride levels. And we can also see hydrochloric acid that is lost from the stomach, which would mean that we're losing acid inside of the stomach, which would make a more alkalotic environment. So you do see some alkalosis in the body as a result of low chloride levels. When you see excessive perspiration, again, when you perspire, you're losing sodium, so you're also losing chloride levels. It is associated with fever and even strenuous labor. You do see hyponatremia in comparison with hypochloremia as a result. Most times you'll see this in dehydration. So the effects of hypochloremia are more nausea and vomiting. You have diarrhea, confusion, sleepiness, and muscle twitching. When you have hyperchloremia, this is involved with an excessive intake of sodium, which means that you have sodium chloride, so you're taking them in tandem. It can be caused orally or intravenously, so we have to watch what type of fluids that we give our patients and how much we're putting in them, because it can cause hyperchloremia as well. So the effects are just simple. You see weight gain because of the fluid, and you also see edema. And again, it is important to note that relationship between sodium and chloride. Now we're switching gears here. We just finished talking about fluid electrolytes and their imbalances. Now we will start talking about acid-base imbalances. So this chart is really nice because it shows you the relationship between pH and what acidosis looks like versus alkalosis. So you have the normal values of 7.35 to 7.45, and then you have that medium range 7.4. So normal falls in between 7.35 to 7.45. When we start talking about less than 7.35, then you have a more acidotic state. This means that you have increased hydrogen ions in the body. As we get lower in the spectrum, even down to 6.8, you'll start seeing death of a patient when they're severely acidotic. On the other side of this chart, you'll see alkalosis, and this is characterized by decreased hydrogen atoms inside of the body, or hydrogen ions inside of the body. So as you see greater than 7.45, as we move down to the 7.8 level, we do start seeing death because of the increase in the alkalotic state. So this is really important to kind of look at, and it's a really nice chart to familiarize yourself with. In order to talk about the control of serum pH levels, anytime we talk about serum, that's blood, so the blood levels in the body, we're talking about pH here. And when we have acid base imbalances, of course, this means that our pH is thrown off. So there is something happening, whether we're acidotic and we're no longer between that 7.35 to 7.45, or we're alkalotic and we are greater than that 7.45 level. Control of your serum levels in the body is very important. So let's talk about what our body does to help compensate or help control our pH levels. We do have a buffer system that responds to pH changes immediately. So there are times where our body does become slightly acidotic or slightly alkalotic. These buffer systems help to maintain it within a normal state. That way, our body does not suffer from being in a alkalotic or acidotic state for too long. So the first buffer system is the respiratory system, and this buffer system alters carbon dioxide levels, and normally this responds fairly quickly. So when we talk about the respiratory system, that is the act of breathing in and breathing out. A lot of the times when we breathe out, we are breathing out CO2 levels, and CO2 is considered an acid, or we can call this carbonic acid. And when we change the respiratory rate, we change the level of carbonic acid in the body. So as we're blowing, let's say we blow off CO2, we're breathing really fast and we're exhaling a lot, that means we're getting rid of a lot of CO2. This causes our bodies to become alkalotic. And so when we have the loss of carbonic acid or carbon dioxide, with the increase in respiratory rate, we do get into this alkalotic state. Or if we have the reverse habit, let's say we're breathing too slow and we're holding on to CO2, this creates a more acidotic environment in our bodies, and it causes us to be in an acidotic state. The next buffer system we'll talk about is the kidneys. And so the kidneys help to deal with the excretion rate of acids, and it also helps with the absorption rate of the bicarbonate ion. So when we think about bicarbonate is more of our base or our alkalosis component. So when the kidneys are absorbing more bicarbonate ions or particles, that means that we're holding on to more base. That means that we are more alkalotic. When our kidneys are excreting more bicarbonate ions, that means that we are getting rid of our base component, which would make us more acidotic. So these two areas, the respiratory system and our kidneys, they are acting as a buffer to help alter the carbon dioxide levels or even the bicarbonate levels. Now, when we talk about the lungs, let's go back to the respiratory component. The lungs can only change the amount of carbon dioxide equivalent to the amount of carbonic acid in the body. They act very quickly. So it only responds to what it can as it's breathing in and out. Whereas the kidneys, they're more slow to change to help compensate for pH. But however, even though that they're slow, they're actually really, really good at their job, and they are considered the most effective mechanism. So lungs, they act the quickest, but may not be as effective over time, whereas kidneys, although they're slow to compensate, they are effective over time. So just make sure that you remember that. So when we talk about buffer systems, just know this overall. You do have like buffer pairs in addition to the respiratory component with our lungs and the kidney component with bicarbonate. You do have the sodium bicarbonate and carbonic acid system. You also have the phosphate system, the hemoglobin system, and the protein system. These are buffer pairs that help maintain pH status in the body. I'm not necessarily testing you on those four areas. I really want you to focus on the kidneys and the lungs. However, this is just good information to know. So this is an excellent chart that talks about acidosis versus alkalosis. So the first one we'll talk about is respiratory acidosis. And again, this is where our CO2, we have a lot of it circulating through the body. So we characterize this by an increase in carbon dioxide levels. And again, it can be caused by a lot of respiratory issues. You can see this in ARDS, you can see this in pneumonia, you can see this in COPD, you can see this in various respiratory conditions that cause what we call congestion. So you do see shallow respirations. Oh, and another note, you can also see this in people that have alcohol toxicity or have started to have issues when they drink too much alcohol. They also can go into respiratory acidosis. So, again, the effects are increased CO2 levels. And when the body realizes that CO2 levels are increased, you start to have the kidneys kick in place. So the kidneys are going to try and compensate by hopefully reabsorbing more bicarbonate because that's what it's supposed to do, the base component. You try to get more reabsorbed. And you try to excrete more hydrogen ions because hydrogen also creates an acidic environment. So when that happens, you do start seeing compensation. Um, Unfortunately, though, this is only short term. When we have a compensated state, our pH tends to stay between 7.35 to 7.4. So let me explain a little bit further about what compensation is doing. This is our body's effort to try and correct the pH, but again, this is not a long-term fix. As we discussed, the kidneys are effective at doing this, but eventually the kidneys will get tired of functioning in this state. The body will get tired of functioning in this state. So you can compensate, but for so long until the body starts failing. And this is where we start seeing decompensated issues with your respiratory acidosis. So even with the kidneys trying to compensate or bring in more bicarbonate ions, eventually you still see a decrease in pH, which still makes you in an acidotic state. So, decompensation is not a good thing, it's actually a bad thing. Again, your body is going to fight, and it's really smart. It'll try everything it can to prevent this from happening, but eventually the body does get tired and it can't do this for very long term. So, if you do recognize the patient is in an acidotic state, there are interventions that are required to hopefully help correct it, which in this case you would correct the underlying cause if they went into respiratory acidosis due to a alcohol intoxication where you want to correct the alcohol levels in the patient. You want to make sure all of that is drained out. If it's due to pneumonia, you want to make sure that you're treating the infection. If it's due to ARDS, normally the patient is ventilated or they'll end up on a mechanical ventilator for this reason. So this is why it's important to recognize these things early. That way the body doesn't have to compensate and unfortunately get to a state of decompensation. The next thing we'll talk about is metabolic acidosis. So this is where we have a decrease in bicarbonate ions, our base component. So you can see this in individuals that go into shock, DKA, renal failure, diarrhea. All of these are major causes of metabolic acidosis. And again, the effects are a decrease in bicarbonate ion levels. You do have rapid and deep respirations as a compensation mechanism. Again, our metabolic component is where our kidneys are not doing what they're supposed to. So, again, the kidneys are excreting too much of our base component. So the lungs are going to recognize this. So we start having deep respirations, and what that does is that it blows off CO2 to help us become more alkalotic. So if we get rid of CO2 component with respirations, the body is trying to compensate. And another way the body tries to compensate is that the kidneys try to excrete more acid as well, or that hydrogen ion. and it'll try to increase more bicarbonate consumption. Um, However, this is only a short term thing, and eventually the body gets tired once again, and you do have decompensation. Once decompensation happens, you do see that pH decrease again, and you still have a metabolic acidotic state. So, compensation again for your acidosis. Generally, your pH will be from 7.35 to 4, but at the point that it decompensates, then you see your pH levels fall below that 7.35 level, even though your body is trying to correct for the bicarbonate and for the CO2 levels. So let's talk about respiratory alkalosis then. You have this caused by rapid respirations. Normally, it is characterized in individuals that have panic attacks or anxiety. You can also see respiratory alkalosis in those that have aspirin overdose, which is characterized with too much aspirin, of course. And one of the issues that occurs is that you start breathing very fast. The result is a decrease in CO2 levels, and when we have a decrease in CO2 levels, the body becomes more alkalotic. The respiratory alkalosis ensues. So, what the kidneys are going to try to do is that they will try to hold on to the hydrogen ions they have because hydrogen is an acidic component, and it'll try to um, not absorb bicarbonate. So, what that means is that the base component is not being used as much. The kidneys are not going to use the base component or bicarbonate, and it'll try to keep the hydrogen ions to hopefully correct the alkalotic state. So again, you do have a low CO2 level as a result. Generally, when we have alkalosis, your compensation looks like a pH of 7.4 to 7.45. So, at the point that the body is trying to fix itself, you do see a more normalized pH. However, when you decompensate, again, the body is only going to do this but for so long until it gets tired. You do see pH levels increase to greater than 7.45. The next one we'll talk about is metabolic alkalosis, and this can be caused by vomiting. And when we talk about vomiting, it's just one of the very early stages of vomiting. So, you do have vomiting that can cause metabolic alkalosis, or you can have excessive antacid intake. So, when we have an antacid, this is something that's just what it says. It's an anti-acid. So a lot of times we take antacids when we have GERD or a lot of acid reflux. So antacids help us to decrease the amount of acid in the gut. Well, if we have too much or excessive intake of this antacid, we're correcting for the acidity in the stomach, but eventually that can turn into a more alkaline environment, and that can send somebody into metabolic alkalosis. So the result is increased bicarbonate ions. So the body has more bicarbonate ions or base components circulating. You do see shallow respirations as a compensation mechanism. And the shallow respirations is because we're trying to hold on to CO2 to hopefully help correct the base issues that we're having because we're in metabolic alkalosis. So you will start seeing elevated CO2 levels as well as elevated bicarbonate levels during compensation. Again, when we are compensated, we sit in a value between 7.4 to 7.45. When we decompensate, unfortunately, the body can't compensate for too long, and then we see our pH increase to greater than 7.45. So again, when we discuss metabolic alkalosis, this is more so due to the loss of hydrogen ions through the kidneys or GI tract. This is very heavily a GI issue, and again, it's more so due to vomiting or if we have acid increases. So take a look at this chart. It's a really, really good chart, and it helps simplify what acid-base imbalances look like. It also gives you major causes of the acid base imbalance, which I love. So just make sure you familiarize yourself with this chart and you dive into it. So on our last slide, I talked a lot about compensation. And what this is, I want to talk a little bit more about compensation because it's a very important concept. This is something that the body is trying to do in order to fight the imbalances that ensues. So it is normally a short-term thing. Compensation does not last long. It does not last forever. This is why if the body is compensating, we get worried because we're not necessarily correcting the problem. We're just maintaining the problem until it gets worse. And that's when you see decompensation. So it's important to know that compensation doesn't remove the cause of the imbalance. So a lot of our acid-base imbalances, you have to correct the underlying cause. If it's respiratory acidosis, you have to remove the cause of alcohol intoxication, or you have to remove the cause of the pneumonia, treat with antibiotics. If it's metabolic alkalosis, it could be triggered from the use of ANS acids, so you would have to remove the ANS acids from the individual, so on and so forth. So you do have to look at what is the underlying cause of what is happening with this acid base imbalance. Um, and it's also important to know that compensation occurs relative to the proportion of hydrogen ions and bicarbonate ions. So this is one of those buffer systems I had mentioned earlier. You have hydrogen ions that are circulating, and the kidneys work very hard to either excrete them and retain bicarbonate, or to excrete bicarbonate and to retain hydrogen. This buffer system is really efficient. It's long term because it happens in the kidneys, but it is very, very efficient. But again, compensation is not meant to be a long term fix. It's only the body's effort to um, hopefully correct itself until intervention is completed. So the body is trying to maintain pH balance when we're talking about compensation. Again, when we have decompensation, that's when the body is no longer able to maintain. The short term time has now completed, and now we are in a state of the body can't handle this anymore. So, this is when you normally see the increases that are not able to be corrected as efficiently, and unfortunately, death can ensue, or very serious harmful things can ensue if the body is decompensation from an acid-base imbalance. So here are two examples of compensation in detail that I'll discuss. Um, the first one is respiratory acidosis, and this is due to a lung issue. You have COPD type um, conditions, one of which is called emphysema. Emphysema is characterized by an individual retaining CO2. Emphysema is not a reversible disease, and in fact, once the damage is done to the lungs, you do quite often see individuals flip into a respiratory acidotic state because the lungs are not able to respond as effectively. So, when we're in respiratory acidosis, this is where an individual has increased CO2 levels. So you'll see the kidneys compensate or increase the um, the production of bicarbonate, a base. And once you see that increase, it's not necessarily noticeable on your ABG yet. The next thing is that you see very high increases of respiratory acidosis. Again, the kidneys recognize this, and so they start to reabsorb more bicarbonate, and they're trying to kick off a lot of the hydrogen ions. So you'll start seeing an elevation in your bicarbonate. Eventually, you do have compensation, and although you have bicarbonate levels that are off and you have CO2 levels that are off, normally the serum pH is somewhere between 7.35 and 7.4. At the point of decompensation, let's say that not only does the patient have COPD or emphysema, but they also catch another disease like pneumonia, which does happen. So if this is occurring, pneumonia is more fluid buildup in the lungs. You're not able to breathe. It's a bacterial infection most times. um, the body is responding not only to the pre-existing comorbidity of emphysema, but now we're fighting a bacterial infection such as pneumonia. So that further increases the amount of CO2 that the body holds on to. So at this point, the kidneys are not able to maintain compensation because it's fighting too many things. So you start seeing the central nervous system uh, to take effects. You start seeing loss of consciousness or even coma, and your serum pH does drop below 7.35. And normally, at this state of decompensation, the pH is around 7.31. So, this is where you have a more detailed description of how respiratory acidosis can be compensated for. But with different comorbidities, you can see how this will make it very hard to fight. And then the body just unfortunately does not respond very well. Okay, so the next one we'll talk about is metabolic acidosis. And this example involves an individual that is in DKA. You'll hear me talk a lot about DKA. As a reminder, diabetic ketoacidosis is a blood sugar disease. More specifically, people that have diabetes can develop this because their blood sugars are uncontrolled. So, diabetic ketoacidosis is a condition of having elevated blood sugars that have not been controlled by insulin. So, when we say insulin deficit, that means that they haven't, their bodies don't create insulin to help protect them from the high blood sugars, and they weren't either taking their medicine or weren't taking it appropriately according to their skills that were prescribed by their physician. So, when metabolic acidosis, you do see a decrease in bicarbonate ions. Again, this is your base component, and that has decreased due to the fact that your insulin, you don't have enough insulin circulating, patient's blood sugars are elevated, so on and so forth. So the patient's in metabolic acidosis. You have keto acids that are produced by the kidneys, and eventually they try to buffer up or use the bicarbonate. So this is where you start seeing why metabolic acidosis happens. Keto acids are a byproduct of diabetic ketoacidosis. The body metabolically creates these keto acids. So keto acids is a type of acids you have a buildup of this acid. So either they bind with the bicarbonate, or they use up the bicarbonate ions, which takes them away from circulation in the body. So here we have an acidotic state due to the decrease in bicarbonate ions. So next, your body is trying to respond. So the component that will respond to kidney issues is your lungs, right? So your lungs, they become not only fruity because you're having a sugar issue, but they become very fast, rapid, deep. This condition is characterized by Kussmaul's respirations. And what this means is that your body is trying to blow off the acid component or the CO2 to hopefully help correct for what it has already lost in this metabolic state. So you're trying to correct for acidosis, you blow off CO2, you become more alkalotic. This is compensation. So again, this will hopefully help drive you to a pH of 7.35 to 7.4, excuse me, 7.35 to 4. But sometimes the body can't keep up with this very long. So when we have decompensation, especially in metabolic acidosis, your keto acids, they increase at a faster rate, and the kidneys no longer can keep up with that faster rate, and your lungs can no longer keep up with that faster rate. Because eventually this person keeps breathing, breathing, breathing. We're going to have to put them on a ventilator to stop them from breathing if it's that severe. Um, so eventually the serum pH does drop below the 7.35, and again, you do start seeing lower pHs around the 7.31 mark. So again, when we talk about compensation, this is the body's effort to try and correct itself when these imbalances occur. But again, when we decompensate, this is not successful. And so the body does have major changes as a result of that. So do familiarize yourself with what compensation is and just make sure you really understand what the body is trying to do in that particular metabolic state. Here's a more detailed description of your metabolic imbalances with compensation. So, in metabolic acidosis, again, we have a decrease in bicarbonate ions in the body. So, what we're doing is that the lungs, they try to blow off more CO2. So, you're hyperventilating, you're blowing off really fast in hopes of trying to get rid of the CO2 component, which will hopefully make the body more alkalotic. Your kidneys are also going to activate and they're going to try and conserve the bicarbonate ions that it already has, and it's going to try and excrete more hydrogen ions. In order to correct this issue, normally we give a lactated solution that hopefully converts in the body to bicarbonate ions in the liver. So we didn't talk a lot about the liver, but normally lactated ringers or a lactate solution, we give that, and the liver is going to create bicarbonate ions as a result to hopefully help correct for the loss of bicarbonate in this situation. The next one we'll talk about is metabolic alkalosis, and this is where we have too much um, bicarbonate ions circulating in the body. So the breathing is suppressed or it decreases. And so, in an effort to maintain the acidic component or that CO2 inside of the body, normally we will treat with a chloride containing solution. That way, the bicarbonate ions can be replaced by chloride ions in the body. So this is what we would do as far as treatment for a metabolic alkalosis state. We'll treat with a lactated solution, whereas with a metabolic acidotic state, we'll treat with a chloride solution. Okay, the next imbalance we'll talk about is respiratory acidosis. And again, this is where we have too much CO2 in the body. So the kidneys are trying to conserve the bicarbonate that it already has, and it'll try to excrete more hydrogen ions. Normally, when this imbalance ensues, we will try to treat with a lactated solution to hopefully get more bicarbonate ions converted in the liver. If it's respiratory alkalosis, this means that we're blowing off too much CO2 or we're hyperventilating. So the kidneys are going to try and conserve the hydrogen ions and eliminate or excrete more bicarbonate ions. We normally treat with the chloride solution when it comes to this. So both of these charts are really good. Even on the last two slides, I would familiarize myself with this because it just further sells what is happening with compensation. Okay, so you should recognize this chart. We have seen this chart before. One thing that I want to highlight about decompensation is that more oftentimes these problems do become more severe, and it is threatening. When we're at the point of decompensation, again, the body has not, or it has done everything that it can do. So you do start seeing your system shut down, and it does require immediate intervention to hopefully maintain homeostasis. So giving those lactated solutions when you have acidosis states, giving the chloride solutions when you have the alkalotic state, even correcting the underlying cause quickly. Hopefully, you can prior to decompensation, but again, if it's not fixed, then we do see decompensation and it is life threatening. So, this is a issue that should be watched for in your practice. Sometimes people do look a little bit weird or funny when they're starting to decompensate. That should be a cue that something is wrong and something does need to occur to hopefully help this individual. So just make sure you look at this chart again. This is the chart from the previous, I want to say 2 or 3 slides ago that talks about what is happening with compensation. But the point of this slide is to tell you that, again, if these problems are not corrected, it is life threatening. So overall, we do have treatments in place to help hopefully correct. The first line of treatment is to hopefully correct the underlying cause. So whatever is causing the electrolyte imbalance, you want to treat that first. But if the patient remains in that, there are different things we can do in the healthcare field to help correct the imbalances, especially when it comes to fluid electrolytes. Even acid base balance, we do have treatments available. So, first of all, if it's a deficit or we have a hypo state, we need to look at how much fluid that we're giving that person, because a lot of times if we're giving them too much fluid, then their electrolytes are going to be off simply because there's more fluid compared to the amount of particles, solute, sodium, potassium, magnesium, so on and so forth, calcium. So we need to monitor the fluids that we're giving a patient. And a lot of times we may put them on a fluid restriction as a result of that. Also, we may opt to replace if it's not necessarily the fluids that are wrong, maybe they're just low in that particular electrolyte. We will replace the electrolyte, and that's where we'll see the replacement with potassium or magnesium supplements. We do give calcium supplements as well, but again, these are things that you can do PO, but sometimes if it's that aggressive, we may have to replace via IV. So if that's the case, then we have to treat it appropriately. The next thing that we'll look at is maybe just removing all of the fluid that's on the patient. So we may opt to use a diuretic, and depending on the type of electrolyte imbalance it is, may determine what type of diuretics we use. So the ones that we've highlighted in this lecture were loop diuretics. They normally take off not only the fluid and the potassium levels, and it can cause hypokalemia when you use that. We may opt to use a separate one called spironolactone, or a potassium sparing diuretic. And what that does is that it solely focuses on removing the fluid, and it'll leave your electrolytes, particularly potassium, where they are in the body. You want to make sure that you are careful when you adjust fluid levels. And again, this requires that you speak with a physician. That way, that electrolyte imbalance is maintained, because sometimes they're just giving the patient too much fluid and they just need to taper that down. You could be giving them 125 mLs an hour of just normal saline when they may only require 75 mLs an hour to maintain hydration. So that's something that you can also look at. We also do add bicarbonate to the blood to help reverse acidosis. So bicarbonate is a base component. We do have a fluid bag called sodium bicarbonate. And what that does is that it helps to reverse acidosis by adding more base component back into the blood. But it's important to monitor your levels as you're giving this medication, because you can accidentally throw somebody back into metabolic alkalosis due to the increased amount of circulating bicarbonate. Um, Less aggressively, you may want to just maintain an appropriate diet. Sometimes we just have these electrolyte imbalances simply because we're not eating very well. Um, and then there are existing comorbidities, as we've discussed before, that can send someone into a acid-base imbalance. Respiratory disorders, a lot of times you see that with your COPD type patients, those that have emphysema, chronic bronchitis. Sometimes you'll see this in individuals that have chronic kidney disease or even end-stage renal. You also see this in individuals that have issues with diabetes. Sometimes hormonal imbalances can have effects on your fluid electrolyte imbalance. Again, we talked a lot about Cushing's and the presence of your mineral corticosteroids or your glucocorticosteroids. We talked about hypothyroidism, hyperthyroidism, parathyroidism, all of these isms that can have an issue. And these are hormonal imbalances. So a lot of times if it's a hormonal imbalance, we try to treat the hormone that is out of whack, and you'll start seeing corrections in your electrolyte balance. So just make sure you familiarize yourself with the concepts that we discussed earlier, and that'll conclude this lecture. Thank you so much for listening. I hope you learned a lot from this. Just make sure that you review your chapters, do your questions as needed, practice questions, and just review any ancillary materials that I may give you in class. And as always, you're more than welcome to reach out if you have any questions. Thank you, and I'll see you in class.